This afternoon, we welcome you to the sponsored symposium by LFB Biopharmaceutical, looking at are all fibrinogen sources the same? The chair is Dr. Rhona Maclean and Professor Nikki Mutch will be presenting. Dr. Rhona Maclean is a consultant haematologist specialising in haemostasis and thrombosis at the Royal Hallamshire Hospital in Sheffield. She's the Trust Lead in Thrombosis Prevention and is also Director of Haemophilia and Thrombosis at the Centre. Her research interests include bleeding and thrombotic disorders and obstetric haematology. So without any further delay, I'll pass over to Rhona. Thank you.
Thanks, Jo. I'd like to thank Jo and Thrombosis UK for inviting me today to chair this meeting and for developing this fantastic virtual conference. For those of you that are unaware, the Thrombosis UK virtual conference in 2021 was awarded the World Thrombosis Day Activity of the Year Award, which is absolutely fantastic, and this event's bigger and better. So thank you so much for joining us. I'd also like to thank LFB for their generous sponsorship for this session, which is entitled Why Should We Replace Fibrinogen? So I've known Professor Nikki Mutch for a few years now, and was delighted to hear that Nikki was awarded a personal chair at Aberdeen University last year in 2021, not least because I'm an alumni of Aberdeen University. It's where I took my medical studies. Nikki studied for her PhD at Aberdeen and then subsequently moved to Illinois to work with Professor James Morrissey, who's now Chief Editor of JTH as a postdoc. And then following an award of an independent research fellowship, she returned to Leeds and then subsequently back to Aberdeen with a British Heart Foundation fellowship in 2017. So Nikki's research interests are the molecular and cellular mechanisms which underpin hemostasis and the perturbations in thrombotic and hemorrhagic pathological conditions. Nikki's well over 60 publications to her name, the majority of which are peer-reviewed original research, but also articles, editorials, chapters and books. And she's currently the president of the BSH, the British Society for Haemostasis and Thrombosis, and is active at the ISTH, recently stepping down as SSC chair and has been nominated for council. So it's my great pleasure to hand over to Nikki, who's going to present to us about why we should replace fibrinogen. Thanks, Nikki.
Thank you, Rhona. That was a very kind introduction. And it's really a pleasure to be invited here to speak to you about some work that we have been doing on different fibrinogen sources and their role in terms of trauma-induced coagulopathy. So I'm just going to share my screen now. Okay, so hopefully everyone can see that. I am going to... Slides are not advancing. 1 second. Right. Okay, so we're all very familiar with this complex coagulation cascade. And while I'm not going to go through it all in detail, I want to draw your attention to this terminal portion of the cascade where we see conversion of fibrinogen into fibrin through the action of the procoagulant enzyme thrombin. Fibrin then forms the matrix and the building block of the clot that is formed, and it's anchored into the platelet aggregates. Why are we so interested in fibrinogen? Well, as I said, it's really the building block of the fibrin clot in itself, and between the platelets and fibrin, that is what stems the vessel from injury and also prevents infection. Trauma-induced coagulopathy is very prevalent worldwide, and the hemorrhagic complications associated with TIC are very acute. And one of the interesting facets of this complex disease is that fibrinogen can be depleted very rapidly over and above other coagulation factors. And this is surprising given the fact that fibrinogen is actively circulates at a much higher concentration than most of the other coagulation factors. This depletion can come about through various different reasons. It can be due to hemodilution with other blood products. It can be due to fibrinogenolysis, which results in loss of fibrinogen due to activation of the fibrinolytic cascade. But really, we're only in the infancy of understanding this, the etiology of TIC. Nonetheless, it looks like replacing fibrinogen is very beneficial, and there's been some very interesting studies showing that fibrinogen replacement, either in the form of a purified source of fibrinogen or as cryoprecipitate, can really be beneficial in a TIC setting. So to go back to fibrinogen and its polymerization into fibrin, which is the insoluble part. So fibrinogen is obviously a soluble molecule that circulates. Fibrinogen is cleaved by thrombin, and this cleavage results in release of FPA and FBB from the fibrinogen molecule. The fibrin then spontaneously polymerizes, forming a monomer, a subsequent oligomer, and a protofibril. And this fibrin that forms has extraordinary mechanical properties, and these are determined by the structural features both at the individual fibrin monomer, to the fibers, and the overall mechanical aspects of the branched fiber network. Why is fibrin so special though? And it's special for a number of different reasons, not only that it can that it forms the blood clot, but also in the way that it anchors different components into the forming clots to form a stabilized network. And we can see here in this lovely SEM image that we have that within the fibrin is embedded a number of the other blood cells. So we have white blood cells, there's platelet aggregates, and there is also red blood cells contained within there. Fibrin also has remarkable extensibility, and that confers mechanical stress to the fibrin network and also resistance against fibrinolytic degradation. It also acts as a reservoir of proteins, and within the fibrin network and bound to the fibrin network, there are a number of key components of the coagulation cascade. And it's really through the interaction of fibrin with these different proteins and molecules that stabilizes the network considerably. And you can see here proteins and inhibitors such as alpha-2 antiplasmin, which then prevent early degradation of the clot. Factor 13, which is a transglutaminase enzyme that's activated by thrombin, also stabilizes the network, forming cross-links both within individual fibrin strands and cross-linking important inhibitors such as alpha-2 antiplasmin into the forming fibrin clot. Fibrin also acts as an assembly point for plasminogen and TPA, and in fact accelerates TPA-mediated plasminogen activation over 1,000-fold. So fibrinogen supplementation in a clinical setting is generally through two different sources. That can be either a concentrated fibrinogen preparation, which is essentially a fibrinogen that is purified from plasma, but has the advantage that it can be delivered in a rapid dosage and defined dosage, or cryoprecipitate, which is a concentrated form of derived of frozen plasma, which contains a number of different coagulation proteins in addition to fibrinogen, including von Willebrand factor and some fibrinolytic proteins such as alpha-2 antiplasmin. So to look at the efficacy of both different fibrinogen sources, we had to create models of TIC. This is rather complex to do because thankfully most TIC patients are given tranexamic acid in this current day and age, and as a result of that, it becomes very difficult to look downstream at the fibrinolytic degradation of these various clots. But in terms of a model in the laboratory setting, we have two setups where we can look at either supplementing fibrinogen depleted plasma with various sources of fibrinogen, and we can do that within a range of that is clinically relevant, or we look at a hemodilution model of TIC in which whole blood is diluted, and as a result there is reduced fibrinogen concentrations, but has the advantage that it has the blood cells present. So if we focus initially on the fibrinogen depleted model, and we look at how clots form by visualizing turbidimetrically the formation of the clot, we can see here that we have the two fibrinogen sources, which are rheostat and fib clot, and we have reconstituted these into the fibrinogen depleted plasma over levels of 0 to 2 mg per ml. And what you'll visualize here is that the rheostat, the clot that forms, is as a reduced turbidity, whereas the clot that forms with both cryoprecipitate and fib clot has a much higher turbidimetric, or what we would call a maximal absorbance, which relates also to the structure of the fibrin clot that forms. And this is depicted down at the bottom, where we've got the correlation between the fibrinogen concentration and the maximum absorbance. And you can see here that that both cryoprecipitate and fib clot were superior in restoring that maximal absorbance. If we look very specifically at the clot acceleration, and that is that initial slope of clot formation, we see again that that rheostat is not as efficient as either cryoprecipitate or fib clot, and there's not a concentration dependence in restoring that maximal absorbance or restoring the clot formation. So that's really where we're looking at those very initial stages of fibrin polymerization. And you'll see here the levels with pooled normal plasma that we do not recapitulate with either rheostat or indeed with cryoprecipitate, but we are able to reproduce these or recapitulate these by inclusion of fib clot at about 1.5 mg per ml. Once formed, the clot is then susceptible to degradation, and so these second set of experiments, we've included tissue plasminogen activator to look at the degradation of the fibrin network. And again, this is done in relation to the concentration of fibrinogen, so it ranges from 0.5 to 2 mg per ml. As the clot's degraded, it loses turbidity. So we can quantify this as a change in 50% lysis of the clots. And what we see here is that we see no clot formation at the lowest concentration of rheostat and a slight concentration dependent increase in the 50% lysis time with the increasing concentrations. But with cryoprecipitate and fib clot, there is a much more pronounced dependence on the concentration of fibrinogen and restoration of that 50% lysis time, telling us that these clots are more stable against fibrinolytic degradation. We then look to see what the factors are, and I mentioned at the beginning that the fibrinogen sources are prepared from fibrinogen derived from human plasma. This is partly because fibrinogen itself is a complex molecule that's comprised of 3 chains, and as yet there is not a recombinant form, and it would be very difficult to achieve this because it requires the alpha, beta, and gamma chains to come together in the correct orientation. So we looked at factor 13, which actually circulates in complex with fibrinogen in plasma. And you can see here that this is expressed as factor 13 per milligram of fibrinogen. You can see that cryoprecipitate and fib clot have substantial amounts of factor 13. And if you remember back to my introductory slides, I told you that factor 13 is really important in stabilizing the fibrin network by forming cross-links between the fibrin strands and also cross-linking alpha-2 antiplasmin into the fibrin network. We also looked at concentrations of alpha-2 antiplasmin. Cryoprecipitate is a rich source of alpha-2 antiplasmin, whereas perhaps not surprisingly, there is very little, negligible amounts of alpha-2 antiplasmin in the fibrinogen concentrates. And once again, looking at another inhibitor of fibrinolysis, Pi1, we see that cryoprecipitate is also a rich source of Pi1, really indicating the additional factors that cryoprecipitate can supply when administered. So we then turned our attention to our whole blood hemodilution model of trauma-induced coagulopathy, and we looked at various different assays, but this one that I'm going to show you initially is the ROTEM assay, which gives us an indication of the clot formation time and the maximum clot firmness, which can relate to both the fibrinogen concentration and factor 13, and also when we include TPA, the lysis time. You can see the classic shape that we get from this thromboelastography, where we form these almost like sausage shapes where we have normal parameters in terms of clotting time and clot formation time, which you can just see in the green and the pink here. but that these are more pronounced in the hemodilution model. And this is recapitulatable. This is shown more clearly, I should say, when we look at the individual parameters. And you can see the breakdown here that in whole blood, we have a normal clot formation time, and this is lengthened, just showing in the hemodilution model, just showing us that we do have a model, yes, but a reasonable model to be working with in terms of mimicking a TIC situation. And we can restore various different components of this by adding in various fibrinogen sources. So we can increase the stability of these clots against degradation. That's seen quite clearly at the bottom here, where we, when we add in fibrinogen at 1 or 2 mg per mil, we can increase the stability of these clots against TPA-mediated fibrinolysis. We also turned our attention to look at the actual structure of the clot, which is really important in terms of its stability and degradation. And on the left-hand side here, this is a clot that's formed with pooled normal plasma, and you can see we have a very nice homogeneous network of fibrin fiber strands. This is recapitulated with cryoprecipitate. Again, we see really lovely straight fibrin fibers that with nice degree of branching. And also with fib clot, particularly at the higher concentrations of 2 and 3 mg per mil. In contrast, we see stunted protofibril growth with rheostat, which is with really knotted regions that are highly branched, which confer a difference in terms of the overall clot structure. And this is just some quantification of the length and the branching of the fibrin network. So when we look at inclusion of different fibrinogen sources, we can see that the maximum clot firmness, which is often used as a measure in a TIC setting, is normalized by addition of the fibrinogen concentrates, both rheostat and fib clot. Whereas in this setting, surprisingly, cryoprecipitate was not quite as effective as the fibrinogen concentrates at restoring the maximum clot firmness. Nevertheless, we still see a nice concentration dependence and correlation between the concentration and the MCF value. We also used an additional analyzer called a Contra analyzer to look at the stability of these hemodiluted clots. And this Contra is also a way of looking really at thromboelastography, but it's a slightly different measurement. It's called Seer sonography, and it uses ultrasonic waves to look at the strength of the clot. And from this, we can derive the clotting time, the clot strength, the platelet, and the fibrinogen component to the overall clot strength. You can see the clot strength is reduced in the hemodiluted model, and this is restored by inclusion of rheostat and fib clot, with, again, like the thromboelastography, cryoprecipitate being slightly less efficient at restoring clot strength. And we can see also that the fibrinogen component to that clot strength is over and above what we would see with in whole blood when we infuse rheostat and fib clot back into the hemodiluted model. Likewise, the lysis parameter, which is shown up here in the right-hand corner, the clot stability against lysis is restored by inclusion of fibrinogen into this hemodiluted model. So I just want to summarize here some of the observations that we've shown you, and really to illustrate that while we can restore fibrinogen through a number of different means via different fibrinogen concentrates or by cryoprecipitate infusion, what we have as an end result is not the same in all these settings. So both cryoprecipitate and fib clot were more efficient at restoring maximum clot firmness, clot structure, and stability against fibrinolysis in a fibrinogen depleted model. The fibrin structure was very different with rheostat, and it was apparent that the fibrin network was comprised very different fibrin fibers, and more work would potentially need to be done to look at the polymerization of the fibrin in more detail. In the whole blood model, we see that indeed the two concentrates appear to be more efficient. And one of the striking differences between these different models is obviously the presence of blood cells in the hemodiluted model. So this is something that we need to think about as to why cryoprecipitate is less efficient in this setting. But again, the other thing that was particularly apparent was the high concentrations of factor 13 in fib clot, and that resulted in it being superior in terms of restoring against fibrinolysis, because it resulted in more incorporation of alpha-2 antiplasmin into the forming fibrin network. So it just leaves me for me to thank LFB for sponsoring this work, and also my colleagues and members of my laboratory that were involved in this work, in particular Dr. Claire White, Dr. Akriti Rastogi, and Michaela Donnarumma and Linda Robertson for performing the analysis. I'd also like to thank other funders, including Tenebris Scotland and British Heart Foundation, who helped fund some of this work. I'm obviously happy to take any questions, and thank you for your attention.
Thank you, Nikki. That was a very lovely, elegant presentation. I don't think we've got any questions yet. Jo, if you just shout out if any questions come through. But can I ask something about the structure of the clots, the protofibrils, and also the intersections? Because it looked like that, and what the relevance of that is. So the intersections appeared to be fewer with the cryoprecipitate and fib clot concentrates, but was far more intersections but less stability in the clots. Is that correct with the rheostat?
With the rheostat, yeah. So I think this is where we get into the complexity of how things work in terms of the kind of the molecular mechanisms. So you could see there that sort of pare it back a little bit, that we had these sort of little short fibrin fibers that were very much balled up, and that's why the intersections come out as being more, because what the measurement is made is the number of different interactions basically that are overlying each other. And so you can imagine those tiny fibers were all overlying each other, whereas what we want is that nice straight line in terms of the fibrin fibers that we saw in the pooled normal plasma, which are generally straight. So this microscopy was done in the absence of cells. So this is something we need to look at, how the interaction of the blood cells will take place in this. But generally, the strength will be determined by the molecular interactions of the fibrin network. And we know this is the case from situations on the opposite side of the coin, that for example, individuals that are predisposed to coronary heart disease and their family members have very, very tight fibrin networks, which are very difficult to lyse. So I think what we're looking at here is that the number of intersections that was quantified as part of this analysis is a poor reflection of what actually happens to the overall network stability.
Okay, and do you think factor 13 was relevant in the development of the structure of the protein?
So factor 13, yeah, that's a very good question, Rhona, and it always surprises me, but Robert Arian's laboratory has done some lovely work showing that factor 13 is not actually as important in dictating that overall structure that we visualize, but is important in dictating the downstream stability. So we don't visualize the cross-linking aspect of it, but it is there, and it's conferring stability to both proteolytic enzymes, namely plasmin, but then also to the mechanical stress, because if you imagine the clots that are formed, these are formed under static conditions, these clots, and we need to take this forward and perform this under flow conditions, such as that would find in the body, because the clots that form there have a very different structure in themselves as well. And also there's the interactions with the cells, because the platelets provide the anchor essentially for the fibrin network. So this is something that still needs to be done.
In clinical practice, of course, we use the Klaus assay to measure fibrinogen concentration, or some laboratories use derived fibrinogens. Is there, obviously with the ROTEM, there were some differences between the different products here?
Yeah, that's an interesting question. And we haven't actually taken it, these and done it with the Klaus assay, but we should, because it would be very interesting to know what we would get in the fibrinogen depleted or the hemodilated model with measuring in the Klaus, because that might have implications in terms of what you are treating a patient with, because it is a functional measurement, the Klaus. So good point. We should think about that.
And do you think we should be choosing our product? Do we think we have enough evidence at this point in time regarding choosing products, whether this is interesting, really very fascinating in the laboratory, but with regards to treating the patient, the important thing is obviously if they're fibrinogen deplete, to give fibrinogen. Do you think we've enough information yet to tailor our product choice?
I think it's still ongoing at the moment, and there is a number of studies. So Dr. Nikki Curry and Dr. Gail Morrow have been doing some lovely work with the Feisty trial. So they've been looking at the early given of rheostat is in that setting or versus cryoprecipitate. So there's some interesting results that are coming out of that I won't go into because I can't at the moment, but they're so we're getting there, we're making progress. I don't think there's enough information at the moment. I think what has been apparent, and is one of the very obviously solid factors, is that it is much quicker to administer one of the fibrinogen concentrates than it is the cryoprecipitate. And so, that's what you're weighing up when you're the clinician, when you're dealing with that on the, can you get it into the patient quicker? And particularly in these very acute hemorrhagic situations where we need to, be able to, restore the fibrinogen exceptionally quickly. So, but probably watch this space, and hopefully we'll come back to you with some more information on that.
It was a fascinating presentation. Thank you ever so much. It was great. And once again, thanks to LFB and to Thrombosis UK for supporting these sessions, which are absolutely wonderful. So thank you very much.